Okay, guys, I hope you all can see my screen now. And welcome to this first journal club of the season 3. And today we are going to discuss a very important topic. I'll just make sure that we are live. Yep, so I think we are live now. And today, this is a very special topic because this is going to be a very popular one in the near future. And you already, many of you are already aware of it. So guys, this is the regeneration era, and we are going to regenerate a lot of stuff. So without taking much of your time, let's start now. So pain medicine world over has got a lot of diverse issues with variable standards, different learning requirements, different offerings. Of course, money and time is something which prevents most of pain physicians to upskill themselves. Mumbai Pain School is an initiative of Pain Spine Wellness and Pain Relief Center. And our initiative has been to bring bridge the education with practice. We've got a lot of traction on various social media platforms like Instagram and Facebook and Twitter. So we are providing online on-demand learning with both free and paid content. Our focus is on hands-on workshops, and we are fortunate to have expert faculty from all over the world. It's said that the best faculty, they teach from the heart and not from the book. This club is nothing, it's just a club. The only difference is that we critically evaluate recent academic literature, which is based on a defined subject. And of course, the audience interaction is extremely important. So I will request all of you to feel free to ask questions, give comments, suggestions, whatever you feel like. Just let me know if anybody wants to speak. I will unmute you and you can speak as well. So it's tough to be regular. So for the next few weeks, just try to be regular so that you cover all the aspects of this particular topic. The first, even Harrison had their own journal club. So I think the importance of journal club cannot be ruled out. He used to do it for critical evaluation twice a month. Time and discipline is important. So I request all the speakers to stick to their timelines. Healthy skepticism or praise is most welcome. This is a bit about me, but today we have with us our esteemed faculty, Dr. Anurag Agarwal sir. He's a very renowned figure in pain medicine, and also the professor at RML Institute of Medical Sciences in Lucknow. He's Secretary of Indian Society of Pain Clinicians. Welcome, sir.
Thank you, Sidharth.
So I think I will now request the presenters. First, I think Dr. Akhil is presenting, I think. So the first part now you can, I have already made you the co-host, so you can just start sharing your screen and maybe we can begin the presentation. So Akhil, can you put your CV slide? I will just introduce you.
My screen is visible, sir?
Yes. So Dr. Akhil Bhalla is an assistant professor in Department of Anesthesia and Pain Management, and he's also in charge of pain medicine at Adesh Medical College in Ambala. He's also founder and consultant of Pinnacle Advanced Pain Management, Chandigarh. So welcome, Dr. Akhil, over to you now.
Thank you, sir. Good evening, everybody. So the article which we are going to discuss today is quite big, and it is a responsible, safe, and effective use of biologics in the management of low back pain, guidelines given by American Society of Interventional Pain Physicians, ASIPP. So these were guidelines given in the Pain Physician 2019, and it was done by Anu Navani, Lakshmi Machikanti et al. So the field of regenerative medicine is expanding exponentially, creating new frontiers in musculoskeletal and spinal pathologies. So the basis of regenerative medicine is based in the process of replacing, engineering, or regenerating the human cells, tissues, or organs to restore or establish normal function. The foundation of it being to stimulate the body's inherent repair mechanism and supplement the process with homologous or autologous biologics when the body itself cannot heal. The biomedical approach in regenerative medicine is based upon three therapies, which is cell therapy, immunomodulation therapy, and tissue engineering. Cell therapy is done by the injection of mesenchymal stromal cells or stem cells and or progenitor cells. Immunotherapy is induction of regeneration by biologically active molecules administered alone or as a complex of infused cells. And tissue engineering is the transplantation in vitro or transplantation of in vitro grown organs and tissues. So these guidelines by ASIPP have been developed to foster responsible, safe, and effective use of biologics in the musculoskeletal system. So the methodology which they used was the objectives being to provide a rational and systematic approach to the application of regenerative medicine techniques in the treatment of low back pain and extremity pain. So the authors had focused 10 key questions which will be discussed over the course of this journal club regarding low back pain and extremity pain. The development group consisted of a panel of experts in regenerative medicine from various medical fields. This was convened by ASIPP and reviewed the evidence and formulated further recommendations. The grading of the evidence is based on RCTs, observational studies, and other clinical reports. Also, systematic reviews and meta-analysis were utilized. The specific levels of evidence offers an approach to grade the quality of evidence, and also the strength of recommendations were seen. The regenerative injection therapy guidelines will be updated within 5 years or less, that is the last being at 2024. So we'll start with the key questions. Key question 1. What is the impact of chronic low back pain and extremity pain on the healthcare resources? And this was a study done in the US. So all these data is from the US. So of course, the impact of chronic pain is enormous. So on the left, you can see a chart showing the types of musculoskeletal pain, and the back pain is much more than neck pain and osteoarthritis and even other sources of musculoskeletal pain. But when you are comparing the same with years lived with disability, the back pain alone is much more than neck pain and osteoarthritis of the knee combined. So the burden is quite high. Coming to the spending on the healthcare in the US, the musculoskeletal disorders gets a massive 183.5 billion, and it is second only to DUBE and cardiac disorders. So the impact of chronic pain, the maximum increase was seen in ambulatory patients, and it was from around $20 billion to around $55 billion in low back and neck pain. And almost similar graph was seen for emergency cases, whereas a slight increase was further noticed in inpatient cases. So there is a definition of chronic pain given by ISSP, but ASIPP defined chronic pain slightly differently. They said that pain that persists 6 months after an injury and beyond the usual course of an acute disease, or a reasonable time for a comparable injury to heal, that is associated with chronic pathological processes that cause continuous or intermittent pain for months or years, may continue in the presence or absence of demonstrable pathology, may not be amenable to routine pain control methods, and healing may never occur. So the estimates of the regional pain vary, but the highest prevalence is low back pain, which is 43%, followed by neck pain at 32%, and lowest in the thoracic spine. So among the total 30 leading diseases and injuries contributed to the years lived with disability in the US between 1990 to 2010, that is 2 decades, low back pain and other musculoskeletal disorders and neck pain ranked 1, 3, and 4 respectively, which is in the top 5. Rank 2 was given to major depression, and rank 5 was anxiety disorder. More recently, another statistics from 1990 to 2016 showed similar results, with rank 1 to back pain, rank 4 musculoskeletal disorders, and rank 6 was neck pain. So the top 5 conditions were consistently primary sources or significantly related to chronic pain. Therefore, it has a very huge burden. Chronic persistent spinal pain is reported to last at least 1 year in 25 to 60% of patients, and even longer than 1 year in many patients. Another study showed that patients experienced 30% to 50% improvement in back and neck pain, but 2 years after their initial visit. However, only 16% patients had complete resolution of back pain and disability at 2 years, despite multiple spinal interventions in these patients. So this comes to question number 2. What are the statistics regarding the trends in utilization of these treatment modalities? So there were some trends which were studied from 1994 to 2016, and a study by Best et al. Assessed the trends in the US between 1994 to 2006, and the number of procedures in per 1 lakh population increased from 6.1 to 34.2 for intervertebral disc disorders and 0.38 to 3.46 for spinal stenosis in per lakh patients. Another study from 2009 to 2009 showed a 2.4-fold increase in the population adjusted increase. Another study from 4 to 2009 showed an increase in the spinal fusions for lumbar stenosis from 21% to 31%, which was not that significant, even though the rate of decompressions were decreased from 52 to 49%. Reoperation rates have been shown to vary from 10 to 23, which is again not significant. 40% of post-operative patients develop post-operative surgery syndrome or failed back surgery syndrome requiring further treatment. So these were the trends which were seen, and you can see that from 2000 to 2006 till 2009, almost you can see a stark increase in the number of procedures which were done for interventional pain. Whereas from 2009 to 2016, the increase in cases was not that significant. In fact, it was even on a slight decline. The same can be seen here. The first graph is for epidural adhesive lysis procedures. The second is for facet joint procedures. The third is for disc procedures. And the last is for all intervention techniques. And the blue shows from data from 2000 to 2009, whereas the red shows data from 9 till 2016. And as you can see, the numbers have drastically decreased from 2009 to 2016. Similar case can be seen for utilization of epidural injections alone in post 2009 and pre 2009. Again, this was comparison of 3-day procedures and 1-day adhesive lysis procedures, which was done from 2000 to 2016. So the 3-day procedures were reduced and 1-day adhesive lysis procedures had increased in Medicare patients. So the utilizations of these techniques have always been criticized for the lack of evidence-based medicine. However, over the years, there have been a magnitude of studies based on RCTs and evidence synthesis demonstrating significant effectiveness of these techniques when appropriately performed. Apart from their clinical effectiveness, the cost effectiveness of these techniques has also been demonstrated over the years. Coming to opioids. So opioids misuse has increased 4,700% from 1996 to 2011. And alone from 2012 to 2017, it has staggeringly increased for synthetic opioids. A study by Matikanti et al. Showed that 94% of the patients were on long-term opioids, and 30% of these patients were taking a combination of opioids and benzodiazepines. A significant proportion of these patients were on high-dose opioids. And if you leave methadone alone, then the synthetic opioids, the usage and the death due to opioid overdose was increased significantly from 2013 till 2017. Again, the opioid usage without any synthetic narcotics was reduced from 2009 to 17. That is, pre-19, it was 179% as compared to post-2009. Whereas when the use of synthetic narcotics was used post-2009, the increase was 898%, which is alone 51% increase from 2016 itself. That is within 1 year. Coming to the cost effectiveness as given by the quality as adjusted for the quality adjusted life years. So as you can see, lumbar epidural, caudal epidural, cervical facet injections, adhesive lysis, lumbar facet joint injections were very highly cost effective per quality or quality adjusted life years as compared to stenosis or stenosis surgery, degenerative spondylolisthesis, or disc herniation surgeries, or even physical therapies for that matter. So that brings us to question number 3. What is the pathophysiological and structural basis of low back pain? So the authors discussed a bit of pathology in the disc, which will be dealt with. So the disc pathology is related to the formation of the disc. I'll not go into the anatomy. So it begins with the nuclear or the annular degeneration, followed by annular disruption, which can be seen here as an annular fissure. Degeneration leads to disc herniation, could also contribute to a central canal stenosis or a foraminal stenosis, and leading to segmental instability or further degenerative growth. So as you can see, due to the fissure, the disc, the nucleus pulposus would come out of the disc, and when it is separated from the initial part, it can be a sequestrated disc, and this can cause compression of the central spinal canal, causing spinal stenosis. So there were few MRIs. This is the T2 weighted MRI scan showing a normal lumbar disc, and this is the conus at the level of the T12 where the arrow is showing. On the right, the MRI shows a disc protrusion at the level of L4-5 disc and causing slight herniation into the central canal. This T2 weighted image shows disc herniation, and in fact, this is a down migrated disc, which is at the level of L4. And on an axial view, you can see the right L4 root being compressed. Similarly, this is a T1 weighted MRI and a T2 weighted MRI showing modic type 1 changes. Also, enterolisthesis can be seen here, and slight herniation into the spinal canal can be seen. Similarly, on this axial view, you can see high density zone, you can see facet joint arthropathy, and foraminal stenosis can be seen. So stenotic areas are depicted in red in this image. Anteroposterior diameter is used as the lateral recess zone, or the entry zone is affected. Hypertrophy of the facet joints can be seen. On a lateral view, you can see the narrowing of the neural foramina, and facet joint hypertrophy can be seen. So they also showed images of congenital narrowing of the lumbar canal. This is an MRI of a patient which is 18-year-old with congenital spinal stenosis, showing multiple disc desiccation at levels of L2 to L5 and causing central spinal canal stenosis. And this was a traumatic case showing a burst L1 fracture with the fragments of the L1 vertebral body pushing posteriorly into the spinal canal and causing herniation and causing lumbar canal stenosis. So the other causes could be low back and low extremity pain, which occurs following lumbar spine surgery in a large proportion of cases, as high as 40%. The incidence of failed back surgery can also be as high as 80,000 cases per year. Again, facet joint pathologies can be there. Degenerated facet lead to discogenic pain because of altered physiology. PGA2 is identified as a key mediator, and it causes inflammation-induced sensitivity and increased neuronal excitability. SIJ pain can be done by diagnostic local anesthetic blocks, having shown the prevalence of SIJ pain in low back pain and low extremity pain between 10% to 25%. This brings us to question number 4. What are the available regenerative methods, regenerative medicine therapies? So the regenerative medicine therapies, so there are two therapies which are mainstays of regenerative medicine for low back pain. That is platelet-rich plasma and mesenchymal stem cells. The platelet-rich plasma has many various growth factors. The most common or the most important ones are the PDGF, that is platelet-derived growth factor, the transforming growth factor beta, vascular endothelial factor, etc. And all of these at some level would stimulate the cell proliferation, stimulate angiogenesis, proliferation, promote the cell differentiation, and promote collagen production and tissue repair. And that being said, there is also some inhibitory proteins present in PRP, that is beta SGF type 2, which will in fact stimulate the over proliferation to be reduced. So the PRP releases platelet-derived growth factor. They increase the fibroblast or osteoblastic activity, reducing the cell apoptosis, promoting angiogenesis, and increased expression of the pro-collagen gene. This in turn increases the tensile strength of the nucleation. So as the PRP is dependent on the function of the host platelet, the therapeutic concentration of the injected is recommended to be at least 2.5 times greater than the peripheral plasma concentration. So lesser concentrations of PRP are probably subtherapeutic, and greater concentrations reduce the osteoclastic activity. So there are many variables which influence the growth profile of the PRP, which would be donor related, the processing of the PRP and the delivery, which is in our hand. Donor related would be age, gender, comorbidities, and if the patient is on any anti-inflammatories, would reduce the PRP quality. Processing, the method of collection and storage, the spin protocol, activation protocol of PRP, and the storage of PRP once done. Delivery in the form of gel or solution, timing of delivery in relation to isolation or activation, and other host factors. So PRP classification was given by Dohan et al. And they grouped PRP on basis of cell content. And they gave it as pure PRP or leukocyte-rich PRP. This is the most commonly used one. And it is always preferred to have a low density fibrin network. And pure PRP does not contain leukocytes and is the most preferred one. Pure platelet-rich fibrin is free of leukocytes, and leukocyte and platelet-rich fibrin is the other type, which is not generally preferred. DPA was another classification given. This was dose of injected platelets, efficiency of production, purity of the PRP, and activation of the PRP. Another classification by Lana et al. Was given as MARPIL, and again it was on the method and the type of PRP which was being used and the process of PRP. The platelet poor fraction of blood is also known to have substances which may be of use, which includes fibrinogen, the alpha-2 macroglobulins, and exosome. We will not be discussing all of those. So the other type of method which can be used is mesenchymal stem cells, or as it is also known as medicinal signaling cells. So the adult stem cells which were described earlier by Kaplan were now called as medicinal signaling cells. So the benefit of these were that they have an inherent lack of significant MHC class 2 surface protein. So this not only allows them to conform to a variety of various cell types when given, but also decreases the risk of rejection when it is transferred between various hosts. That is an allogenic transfer between the hosts. So another mechanism of action is the paracrine influences they have, affecting the efficacy in the differentiation of these cells. So concentration of the surrounding catabolic cytokines from acute inflammation favors the osteoclastic activity, but this balance must shift away from the inflammation in order for the anabolic effects of these cells to take place. So that is important. First, the report of stem cells was described as obvious from the bone marrow, and the bone marrow cells are the most commonly utilized types of stem cells and have the approval and are in the recommendations of the FDA in the US. So there were some consensus statements of stem cell therapy. I will not go into everything, but number one was that the mechanism for the factors contributing to MCS, that these contributions must be characterized. Second, the considerations should include the cell number, concomitant use of growth factors, pre-differentiation of these cells, and vehicle used for the installation. Mesenchymal stem cells isolated from different tissues must be compared to identify the most appropriate source for each specific indication. And number three, a standardized assay of stem cell efficacy is needed. Methods for establishing proof of the therapy to be determined in collaboration with the industry or agencies wherever it is required. The most appropriate control for clinical studies evaluating the therapy in each indication must be identified, and most appropriate replicable outcomes must be established before using the stem cell therapy. So true adult stem cells are scarce. They are very difficult to isolate. They grow slowly and they do not differentiate well. It can be difficult to isolate these cells in sufficient therapeutic quantities which is needed. So this is the disadvantage, but it is partially overcome by the selection of stem cells. For example, such as bone marrow from a source containing red marrow, such as the iliac crest, where the extraction yields 95 to 100% viable cells, is a very good selection. Although the absolute number of cells found in the bone marrow concentrate may be relatively low, these growth factors that are derived may confer additional therapeutic value to the process. So there are many other commercially available biological preparations. The most important one would be exosome or the microvesicle. So these are somewhat similar to the mesenchymal stem cells. They are secretory products that home and travel via local diffusion, delivering proteins, microRNA, and messenger RNA. They can travel systemically without the risk of clumping and do not demonstrate any first pass effect into the lungs also when administered intravascularly. And they are also important in endocrine signaling, that is locally between the same cells, paracrine signaling and endocrine signaling. Again, another would be alpha-2 macroglobulin, which are not that commonly used. And also intradiscal tocilizumab therapy has been studied in discogenic low back pain patients. This brings up to question number 5. How do the regenerative therapies work in the treatment of low back pain and extremity pain? So there was a three-joint theory of spinal degeneration which was given, and it includes intervertebral disc degeneration, facet loading, and degeneration, which would possibly lead to spinal deformity, nerve root compression, and possibly a central canal or a phenomenon. So when we talk about the intervertebral disc, it is made up of various things, and we'll not go into that. Degenerated discs contain cell clusters producing matrix degrading enzymes. This includes MMPs, that is matrix metalloproteinases. Unfortunately, the disc is relatively avascular, so therefore it creates a difficult microenvironment with low oxygen tension and paucity of the nutrients in these disc cells. So there is limited vascular support as a significant contributor to the regenerative capacity of these discs when metabolic hemostasis is disrupted. So therefore, DDD or degenerative disc disease is known as a diffuse, progressive, and an age-related phenomena, and which is characterized by dehydration of the disc and fibrosis, and approximately a 3 to 4% height loss of the disc per year. So the hallmarks would be increased MMP activation. This is the matrix metalloproteinases, decreased intervertebral disc cell viability, and decreased proteoglycan production in these discs. So this is a graphic which explains the pre-treatment and the post-treatment with the stem cells or PRP, which we were considering. So this is the goal of the intervention treatment that which we want. We want a good pain relief. We want improved disc microenvironment and disc regeneration. And as you can see, pre-treatment, the matrix metalloproteinases, the IL-1, TNF alpha are all increased, whereas post-treatment or with pain relief, the annular fissure has healed, there is tissue regeneration, increase in disc height, and reduced matrix metalloproteinases, tumor necrosis factor alpha, and again increase in the IL-10, TGF beta, and nuclear matrix, and of course regeneration of the disc. So despite obvious tissue deterioration, viable cells are isolated from degenerated discs, have shown an ability to proliferate and differentiate in vitro, even though regenerated potential is limited in these discs. So a study by Zexer et al. Showed that intervention therapy should optimally strive to fulfill a trio of treatment. That is, first, it should decline or resolve the primary nociceptive disc pain. Second, slow or reverse the catabolic mechanism and associated disc degeneration in the disc. And third, partial or complete restoration of the disc tissue. So previously, percutaneously delivered stem cells in the disc have recently gained attention because they can revolutionize the discogenic low back pain therapy. They may have the ability to uniquely accomplish three stated objectives in the Zexer et al. Study, which none of the previous interventions could have done. Stem cell therapy address the underlying sources, that is, mitigate inflammation within the nucleus pulposus and restore the disc height. Stem cell therapy in animal models has consistently led to increased disc height, improved MRI imaging, decreased grade of degeneration, and increased expression of type 2 collagen. Another study showed that an injection of 25 into 10 raised to power 10 allogenic cells per disc segment achieved faster and more significant results than controls when allogenic stem cells were given. Another study showed that 26 surgical candidates for spinal fusion or disc replacement surgery, out of which 24 were able to avoid surgery for 12 months, and 21 patients were able to avoid surgery for 2 years following intradiscal bone marrow mesenchymal cell implantation. And none of these patients worsened, whereas some even improved on an MRI-based grading system. While these stem cells are used more commonly for disc degeneration than PRP, PRP has slight benefit with an inhibition of the matrix degrading enzyme as well. So the PRP contains amplified levels of growth factors and cytokines, and they stimulate tissue healing. Over the years, we have seen that higher concentration of growth factors directly at the site of collagen injury promotes their function as well as the humoral mediators to induce natural healing cascade. PRP impregnated gelatin hydrogel when injected into the disc of a rabbit model showed significant higher water content as demonstrated by an MRI, and correspondingly significant reduction in apoptotic nucleus pulposus cells, upregulated RNA precursors, and increased protoglycan content was seen. So in a percutaneously annulus sponge induced disc degenerated in a rat model, discs treated with PRP had fewer inflammatory cells, higher preservation of the normal morphology of the disc, and higher fluid content. So coming to the facet joints, PRP is quite commonly used in the treatment of lumbar facet joints. The PDGF concentrated within PRP are essential to the healing process. Increased fibroblastic osteoblastic activity, reduced apoptosis, promotes angiogenesis, thereby increasing the blood flow circulation to the newly formed tissue, and increases the expression of the pro-collagen gene and the collagen-derived growth factor. So a study by Christensen and colleagues show that the stem cells which are harvested from facet joints and interspinous ligaments had trilineage potential. That is, they could differentiate into osteogenic, adipogenic, and chondrogenic cells under appropriate conditions. This has to be verified with further study. Again, in the SI joint, there has been extensive literature suggesting the use of stem cells in SIJ, but effectiveness also has been shown for biologicals in the management of this joint. So for the next question, I would request Dr. Aanchal to please take up from question number 6.
Thank you, Dr. Akhil. Is my screen visible, Dr. Sidharth?
Yeah, it's visible. Please put up your CV slide. I'll just introduce you. So Dr. Aanchal Sharma is MD Anesthesia from PGI Chandigarh. She's done her fellowship in pain medicine from Chicago, USA. She's board certified from American Board of Pain Medicine, and currently she's working as Senior Consultant, Pain and Palliative Care at Venkateshwar Hospital, Dwarka, New Delhi. Over to you, Dr. Aanchal.
Thank you for the introduction. So we all know that we are discussing this paper, so I'll just skip this intro slide and we'll directly go to our key question. So I have 5 more questions to discuss, but I'll just say that this question number 6 is actually the main question we are looking for our answers while using the PRP. So this question 6 will be in detail, and then we'll quickly go over through the other questions. So this is the level we all know that, since our conclusion will be based on these levels. So I just wanted to highlight that, level 1, 2, 3 are based on some evidence, and then level 4 is a limited evidence, and level 5 is just consensus based. So question number 6, are regenerative medicine therapies effective in managing chronic low back pain? So to answer this question, there was a search which was conducted from spanning from January 2000 to June 2018. And the data sources were PubMed, Cochrane, all the Google searches. And the search criteria was a patient having extensively covered chronic low back pain of various origins and injectable biologics, which included both PRP and mesenchymal stem cells. And study selection was based on predefined inclusion criteria, where studies at least should have reported 3 months of outcome assessment. And the intervention which was included were intradiscal injections, all types of epidural injections, intraarticular injections of facet joints, nerve blocks, SI joints, and ligamentous injections as well. So outcome of the studies were, for the present analysis, they should have reported at least 50% relief from the baseline pain score, or at least 3 points of change from the 11-point pain scale. That's the VAS 0 to 10, what we use, or at least 30-point change on the VAS of 10 centimeters or 100 ml was considered clinically significant to answer whether or not these regenerative therapies are helpful. And this was for the VAS, but for functional status improvement, more than 30% improvement on disability scores or more than 50% improvement from the baseline was considered clinically significant. And the meta-analysis was performed using the version 3.0. And all the analysis was based on each modality of the treatment and solution injected. There was a short-term improvement, which was defined as improvement lasting for at least 3 months. And then long-term improvement was defined as lasting for more than equal to 6 months. And meta-analysis was performed if only when at least 3 studies were available and included an appropriate sample size of at least 10 for non-randomized studies. So these are the, going to our first entity, which is the disc degeneration, the discogenic pain. So these are the study details of the patients who were included with lumbar discogenic pain. You can see these were done in 2016, 2017, and 18, and number of patients were varied from anywhere from as low as 8 to as high as 47. And these patients all got a PRP. And a few of them have mentioned the dosage as well. They did single injections, 2 ml, and up to only the 3 discs. And somebody did 6 single injections. And this is the follow-up period of these studies, anywhere lasting from 6 months to 2 years. So conclusion, I would like to discuss individually, since these are the very few studies and we really need to know whether or not these therapies work. So intradiscal injection of PRP, which was done one time, brought the significant improvement at 8-week follow-up. And this improvement was even maintained till 1 year when they compared it to control. So this is the only RCT which is included in this intravertebral disc degeneration. Rest of them are prospective trial or case series. And another study which also showed that there was a continued safety and improvements in pain as well as function at even 2 years after the procedure. Then our third study brought the conclusion of more than 50% of relief in the pain, and at 6 months, even at 86 months, and along with the improvement in the disability scores. Then the fourth study, which was a clinical trial, preliminary clinical trial, it showed reduction in mean pain scores at 1 month, and which was sustained at the level of 6 months and 12 months. And then single or multiple levels of discogenic pain. For the pain, they injected the PRP, and they showed encouraging improvement with more patients developing improvement over time. But though these studies does show improvement at the end of 3 months, but they haven't mentioned about any immediate post-op improvement or worsening of pain which was seen after the procedure. So this is the one we just discussed.
Dr. Aanchal, may I
Yes?
interrupt here?
Yes.
At this moment, just go back to your earlier slide.
Yes.
It would be prudent if you tell about the only RCT available with the IDD.
Okay.
What was the control? What was the control arm they used?
Compared, so in the control,
they must have compared it. They must have compared the interdiscal PRP with something as a control.
So they did the contrast injections or in the control, but I have to double check what was the exact volume.
It's all right. Please go.
This is the stem cell therapy, which they used for the same intensity, lumbar disc degeneration. And these are the study details. So we'll just discuss these details in this format. So the study details, the studies was done from 2006 to 2017. Sample size was as low as 9 to 24, and all the patient had discogenic pain. So the age group varied from 18 years to 65 years in all these studies. And the solution they injected was allogenic bone marrow stem cells by intradiscal injections of 6 cells per segment, that is 2 to 3 ml of bone marrow concentrate was injected. And the outcome parameter all of these studies measured was VAS, ODI, the MRI changes, and SF12 for the disability. And both the results were both lumbar pain and the disability were significantly reduced at 3 months. And this improvement was maintained at 6 as well as at 12 months. And overall, there was an average 28% improvement in pain and disability 1 year after the intervention, along with the improvement in the disability scores. So the conclusion with the lumbar discogenic pain patients were 70 to 70% of the patients were improved. However, 20 to 23% of the patients still required surgery due to the persistence of back pain. However, there was not worsening of the pain after the injection. So coming to our second entity, lumbar radicular pain, for which lumbar epidural injection was done. So this is the RCT, only RCT done in this. And we will discuss through the table what was the control and what did they actually do. So from 2000 to 2017, these studies had sample size of as low as 20 to 470 in one of the studies. 6 months to 2 years was the follow-up period. As I said, one RCT, one observational study, and one prospective cohort. They had 29 year to 81 year was the population range. All had the similar complaint. And these were the outcome parameters of VAS, ODI, and FRI. So first study, they injected they did transforaminal or perineural injection for 1 week for 3 weeks. So they injected 1 ml of local anesthetic in all the groups, plus group 1 had 5 milligram of triamcinolone. This was control 1. Group 2 was 10 milligram of triamcinolone. This was another control. And then the study group was group 3 autologous serum. This is the interleukin 1 enriched autologous conditioned serum that they had. And this showed similar response with triamcinolone initially, but at the end of say 26 weeks, they had significant improvement in pain, all the 3 groups, but not with the function. So what they say is results were similar to local anesthetic and steroid injection, in whatever the serum group as well. So all the 3 groups had equal amount of pain relief. And another study in which they did intralaminar or transforaminal epidural injection, volume they used was 3.3 to 5 ml. So whatever volume they decided, 50% of that was plasma lysate, 4% was lignocaine, and the 100 to 200 milligram was the hydrocortisone, which consisted of 1/4 of the volume. And they had a significant lower numerical pain score and the FRI change scores at all time points compared to the baseline. However, 1/4 of the patient failed to show any significant improvement. So another study, they did interlaminar injection of with 2 ml of contrast followed by 2 ml of ACS, and a maximum of 3 injections were done. So not all of them got 3 injections. It was a 1, 2 or 3 at the interval of 7 days, but it was based on the clinical response. So the positive results with ACS with disease modifying course was seen because there was a reduction in pain and disability from decrease from 7 to 2 and ODI improving from 27 to 8.5. The 4th and 5th study also were the similar. They used 2 ml of activated platelets. And then another study, interlaminar 2 ml of PRP. This one was observational retrospective study and another was just 3-month follow-up prospective evaluation. And both of them showed improvement in the pain as well as the functional improvement. So the third entity where they used the PRP was lumbar facet intra-articular injection. So they only were able to find 3 studies which had, and only one was the randomized in this, where they compared it to steroids in the control group. So this was the prospective randomized trial in chronic facet patients. So they had intra-articular injection of PRP versus local, and other were just the prospective. So they just did PRP and followed patient accordingly. And one study did the intradiscal, intra-articular facet, and transforaminal all the injections in one patients, in all their patients. So the RCT showed there was a significant improvement in both groups, steroid as well as PRP for short term. But however, long-lasting for 6 months improvement was seen in only PRP group. But they said that it was limited because of small number of patients. And another study showed positive results in small number of patients. They only used PRP. And then another study which injected all intradiscal, intraarticular, as well as transforaminal also showed improvement in VAS as it decreased significantly even at the end of 6 months. So these are our results. So coming to sacroiliac joint pain. So for this, they were able to figure out one RCT and 2 observational studies in which SI joint PRP has been used. So the RCT which was used, they injected steroid in the control group and PRP in the 0.5 ml of PRP in the study group. And they said that the significant improvement in the pain in the both groups, but there was a strong association in patients receiving PRP, which was showing reduction of VAS for more than 50% from baseline. And then there was another, they just injected the PRP and they also showed improvement at the end of 3 months, but it was only 10 patients, positive case series of 10 patients. And then there was a third where only 4 patients were chosen and they were injected PRP and they showed improvement, marked improvement in joint stability even at the end of 12 months, and also reduction in pain and improvement in quality of life. This was a short case series of 4, so all 3 cases. So what was the assessment of evidence based on this evidence synthesis principle? So they say evidence for biological management for lumbar discogenic pain has been assessed as level 3, both for PRP as well as MSC therapy, stem cell therapy. And the evidence for lumbar facet joint, they assess it as level 4 for PRP. And management for low back pain and low extremity pain with epidural biologics, they also assess it at similar level of level 4. And for SIJ, similar level of level 4. So next question is, what are the WHO regulatory guidelines for this use of these biologics? So what FDA or WHO says that HCT/P, which is human cells, tissue, cellular, and tissue-based products, they come under the section 361, and it should meet all the following criteria: that it should be minimally manipulated for homologous use only. It should not involve the combination of cells or tissues or with another article except water or any storage agents. And also, it should not have any systemic effect. And even if it does, it should not be dependent upon the metabolic activity of the living cell. So, and allogenic use is only allowed for 1st degree or 2nd degree blood relative or for the reproductive use. So these are the guidelines, which is laid by FDA. So this paper shows as question 8, 9, and 10. The adverse consequences, harms of regenerative therapy. What are the best preventive and therapeutic strategies to improve the outcomes? And what comprise the responsible performance of regeneration injection therapy? So they have tried to answer all these questions by our next, what we are going to discuss next. So these questions are answered as together. So coming to safety, efficacy, and informed decision, this says that patient should also consider these factors. So when they choose physician, they should know that the physician holds a medical license and is board certified for specific type of therapy they are giving. The consumer should also assess the facility where the treatment is given, whether or not it's safe and what it does in the case of emergency situation. Very important medical claims, the claims such as miracle cure or claims to cure serious condition are not credible, and it also poses significant risk to public health. So these claims should not be done and would only be based on acknowledged scientific evidence and medical experience. Then shared decision making. Patients should be included in the decision making, as the patient-centered care is care that is respectful and responsive to individual patient preferences, needs, and values. So he should be interim part of what our decision should be. And of course, the informed consent, what we do in every case, it is fundamental to both ethics as well as law, and patient has right to receive information, ask questions about what treatment he's going to receive. And successful communication in patient-physician relationship, of course, fosters trust and supports the shared decision making. So guidelines for office setup, it should be highly aseptic. To reach affordability and mass scale, production process should be highly reproducible and validated both on small scale for a single patient and even if for the large scale of the patients. The physician who is performing the procedure should be properly trained and comfortable in performing the techniques, interventions, and they must be ready and available to handle any complication which results and available on call for emergencies that may ensue from the procedures. What are the contraindications for these biologics? It's hematological disorders, platelet dysfunction, septicemia or fever as with our any other intervention, cutaneous infections, hemoglobin less than 10, any malignancy, particularly hematological or bony, and if patient is allergic to them, and of course, severe psychiatric impairment or unrealistic expectation. So this should be covered in the informed consent as well as patient involvement. So in answering these questions, so they have laid some guidelines, pre-injection, intra-injection, and post-procedural consideration for physician as well as patient. So what is the pre-injection management of the patient? We should be checking the candidacy requirements. You know, when we are doing the procedure, we should be sure that patient needs it, and imaging modalities, of course, demonstrate the pathology and help us know the pain generator for the patient. They say we should avoid use of any steroids 2 to 3 weeks before the procedure. So we need to make sure patient hasn't gotten it. And also NSAIDs for 1 week of the procedure. Any necessary anticoagulation precaution should be taken as recommended by ASIPP or ASRA guidelines, as we would do for any other intervention. And also, they say mild sedation can be used, but deep sedation should be avoided so that patient can be arousable and alert at all times. Then the pre-injection management of biologic materials. So they said, as Dr. Akhil mentioned, platelet concentration should be at least 2.5 times greater than the baseline plasma concentration. So the procedure could be clinically effective. The biologic should follow the FDA recommendation, that is minimal manipulation and only homologous use. Cell viability, they say whatever you take should be used in 24 hours. And the tri-lineage capabilities, differentiation and viabilities of stem cells should not be are usually not affected by gauze of the needle you use, but they say that 19-gauge needle actually reduces the incidence of apoptosis. And 2 ml syringe should be is recommended to avoid overinflation. While injecting, these were the pre-injection considerations. So while injecting, we should be considerate of cell material, patient, joint location, affected site where we are injecting, and material should be injected under direct visualization, either with ultrasound, fluoro, CT, MRI, or endoscopy. Then post-injection, patient should be advised for rest and partially immobilizing the injected body part for at least few days to 2 weeks, depending upon where we are injecting. Need to avoid anti-inflammatory medication for a few weeks post-op, as the therapy which we are giving is grounded on the benefit of patient's inflammatory cascade. And also, if patient is on aspirin, we need to see the risk-benefit ratio before prescribing it. Post-op instructions, red flags, pain control measures should be verbally discussed, as well as written copy of instruction should be given to the patient, along with a close follow-up, which is scheduled 2 to 4 weeks post-op and as on the discretion of the pain physician. So coming to the next antithrombotic implication. So first is NSAIDs and aspirin. They say there is little to no risk at low doses, but high doses needs to be, if the clinician correlates their medication status with previous heavy bleeding, it needs to be considered. Also, if the patient is on any additional medication supplements like SSRI, fish oil, garlic, etc., Phosphodiesterase inhibitors like elastazole, etc., do not significantly increase the risk, but may or may not be discontinued according to the patient history, and we can take the help of vascular doctor who started it. And then the platelet aggregate inhibitors like ticlopidine, clopidogrel, and Pradaxa should be discontinued 7 to 10 days, like any other intervention. Warfarin, for high risk interventions, INR should be less than 1.4. For low risk, it can be around 2. Heparin should be discontinued at least 12 hours. For Pradaxa, it depends how patient renal status is. If the creatinine is more than 50 ml per minute, it requires a period of 2 to 4 days for discontinuation. But if it's less than that, at least 4 to 5 days is needed if you are planning for any spine-related techniques. Then what are the effects of the antithrombotic therapy on these PRP and stem cell efficacies? They say that NSAIDs have negative influence on platelets, such as inhibition of activation, decrease in storage of alpha granules, and aggregation of platelets. So the substantial inhibition of platelet functions, such as aggregation, acquired post-stimulation using arachidonic acid with NSAIDs was found. So, and it was regardless of how much longer you used it for, how you gave it per oral or IV, or what technique did you use for PRP formulation. So irrespective of that, the NSAID did inhibit the platelet function significantly. Also, the bioactive compounds such as TGF-alpha growth factors, platelet factor 4, stored in these alpha granules cannot be released adequately if this NSAID NSAIDs bar this pathway, and platelet function is drastically compromised. So we have to be mindful of NSAIDs use. Then coming to adverse reaction and complication, infection, tissue rejection, and changes in characteristic of the cell in the product that may alter how they respond. PRP therapies, as I said, derive their benefit from localized inflammation. So it can cause worsening of pain and sensation of pressure. We need to really talk about this in the consent. Then generalized rest and restraining from the use of NSAID medication. And then final concern for the use of biological therapies is the induction of neoplasms from undifferentiated cells. However, they say that the incidence is not more than what you would see in that particular kind of population. So conclusion is based on evidence, and see, as I said before, level 3 evidence for intradiscal injection of PRP as well as stem cells, level 4 for lumbar facet joint, lumbar epidural, and SI joint for PRP. The regenerative therapy should be provided following diagnostic evidence. We are sure that the PRP we are injecting is into the pain generator, and it needs to be discussed with patient's need and expectations after properly educating the patient, and also use and administration of biologic in full light of patient's medical history, and of course after taking appropriate precautions. Multiple guidelines of FDA which they laid for biologic use needs to be kept in mind as well. So limitation they accepted was the lack of standardization of methodology and analysis. It's a handicap to the ability of to reproduce the same models or make any declarative recommendations. So critical analysis from my side is physicians are still testing new combination of therapy, and hence heterogeneity in composition techniques and outcomes. And then these guidelines, since based on good quality study, at least one RCT, and the prospective trial which they did was as indicated by Cochrane review criteria, gives at least pain physician a little confidence in the new therapy. Along with the use of biologics, they also highlights the safety guidelines for intervention as well as antiplatelet and thrombotic therapy. But of course, more RCTs are needed in this field for providing more conclusive data.
Thank you, Dr. Aanchal. So now I will request Dr. Anurag Agarwal, sir. I think most of you already know him, but I will just introduce him again. So he's one of the first few PDCCs in the country. He's done his MD and PDCC, and also now FIAPM. And He's a pain spine physician and professor in Department of Anesthesiology. Also the Honorary Secretary of Indian Society of Pain Clinicians. He's a founder president of ESIPS, that is the Endoscopic Spine and Interventional Pain Society. He's working at Dr. RML Institute of Medical Sciences, Lucknow, which is an institute of great repute. His achievements are establishment of pain clinic and pain medicine at LLRM Medical College, Meerut, and GSVM Medical College, Kanpur, which I think has a separate pain department. Advancement of pain medicine services at Dr. Ramanohar Lohia Institute of Medical Sciences, Lucknow. And also he's got more than 25 publications in national and international journals. So, sir, over to you now for further discussion. Thank you, sir.
Thank you, Sidharth, for reminding me what I have done till now. So little, so less. It's amazing to listen to the young guns of the pain medicine, and Dr. Aanchal, Dr. Akhil. This was a wonderful attempt from Dr. Navani, if I am rightly naming her, the author. Yeah. So this is something very new, and I think I can dare say that is quite controversial topic of the pain medicine, because pain medicine has embraced this field of regenerative medicine quite late. To the best of my knowledge, though Dr. Aanchal, because she has spent some time in US, can confirm it that PRP was done by the PRP people, not by the orthos, not by the pain people earlier, just few years back. So recently people have got interested into it. As far as the presentation was concerned, it was wonderfully presented by both of you. So congratulations to both of you. It was very well elaborated, marked at the right, you highlighted the right points in the journal, and Dr. Aanchal, you have taken out the right message from the paper also. But I would start to speak about a bit more about what Akhil presented actually, and in his slides, and which is slightly, I can say that it is diagonally opposite of the main topic, which is PRP, biological therapies for the low back pain or chronic pain, but focused on the low back pain. I would like to draw the attention of the audience towards the first few slides, which Akhil mentioned, where he has mentioned, rightly so, unfortunately, we do not have data of our own country, that is India, about almost anything. So we rely upon the US data, which shows us that there is lot of chronic pain patients which are disabled, and the biggest number is because of the low back pain. Second thing, what Dr. Akhil said, that the things which are increasing in number are the actual major surgical procedures, like fusion, like major surgeries, and the number which is coming down actually is of minimally invasive percutaneous interventions, which we pain physicians do. And this is the story of US, which is considered to be the leading country in the field of pain medicine also. So we pain physicians of India, I think, must think and dwell about the reasons why it is happening even in America. Why ASIPP has to try always to advocate for the remuneration of the pain physicians. Why the things are which are actually minimally invasive, they are percutaneous with less morbidity and almost no mortality, are being left behind. Their numbers are drastically coming down below the baseline, and while where there is an incidence of up to 40% failed back surgery syndromes or post-laminectomy syndromes, their number is increasing drastically. Or you can say that they are stable, but at very high numbers. They are costly, they are with lot of morbidity, they are with lot of failure rate, they are with lot of extra price to pay, they are with long-term sequelae, but still their number is increasing. So I think that, I believe that ASIPP is the first organization in US, apart from SIS now, which was earlier ISIS, and other ASPN and so many others. But ASIPP is the only one who has taken care of providing the evidence, though a bit late perhaps, as per their terms, what the figure shows. So the Indian diaspora of the pain physicians, as well as all other countries apart from US, especially of the developing countries where pain medicine is still developing, need to dwell about it so that we do not go to the US way, when your therapies are minimally invasive, percutaneous, effective as the data suggests, but need to be proven, and cost effective, which is very, very important in our country specifically, and many more parts of the world. I believe that many international audience are there. Congratulations, Sidharth. This is a successful story of your Mumbai Pain School. So the rest of us need to think about it, that I do not think that in the recent future, we are going to match Americans in the terms of dollars. So, but still we have a large population to cater upon. Just think about the havoc, the numbers of people who are being on the disability pension in US. God forbid if someday in India it happens that people starts leaving their jobs and starts living on the. So what is the answer? I have talked a lot about the problem, but what is the answer for this thing? That we need to generate evidence for our therapies, and we need to do it sincerely and with all the honesty, and which is approvable on the world accepted guidelines and the scales and schools. So this is something which we need urgently to do, and the burden of this actually lies upon you young guns, Akhil, Dr. Aanchal, and many of other fellows who are here of the pain medicine. You have to be passionate, and you have to be systematic, and you have to be responsible and responsive. You just can't say that once the patient is lost, loss to follow up is the good outcome. So we need to find out ways so that we can follow our patient, and we need to present it with almost all sincerity. So this was this paper actually again ignited me that fire which was inside me, which I always think that why it is happening, why Americans are even. I would just share an incident, and I believe that many of you must be knowing about it. The best therapy for the IDD, that is internal disc disruption or annular tear or discogenic pain, multiple names for the same thing, when there is axial back pain with the sitting intolerance, has been considered till now is intradiscal chymopepin. Perhaps some of you must have heard the name of this drug. Unfortunately, perhaps I shouldn't say it on the international platform, but many of the torch bearers work only for the dollars or euros or whatever you say. They stopped this therapy because there was no money involved. There was single injection involved of the chymopepin, which used to be worked very well. You ask someone who has passed that era, it was in late 80s to late 80s actually, 70s to late 80s only. There was 2-3 complication reports. The fusion industry was booming, started to boom, and intradiscal chymopepin went out of the place. And once America banned it, Indians, we always follow the suit. We also banned it. So currently it is not available in India, not available in America. So this is just an incident that what dollars or rupee or money can do even with the good therapies unless they are linked with the economy. So this is one thing. Now, after the sermons, I would come to the PRP, the basic topic of this thing. I'm really excited. I am really excited to use these regenerative therapies to my patients. But what I do not, I am failed to understand even after this paper, there are multiple studies which have been quoted. So there is no methodology involved. There is only the collection and analysis of the data which someone has done already. So I'm convinced personally that it may work for the internal disruption. You go, it will heal, it will try to heal, and it is again, as Dr. Aanchal in her last slide told us, that the whole premise of all the PRP or prolotherapy different methods is the inducing controlled inflammation. So if it is inducing controlled inflammation, I can imagine in my wild dreams that it may cause some inflammation, in result some fibrosis at the annular tear, and it is sealing that annular tear. And also it is, because it is having some growth factors, it is also helping out to decrease the MMP and to increase glycoproteins in the nucleus environment. Apart from that, personally speaking, I am not much convinced, and also I haven't tried also in the facet joints, in the sacroiliac joints, or especially in the radicular pain. I am failed to conceive that how it can be effective. Suppose for the radicular pain, radicular pain, it is most of the time it is because of the disco-neural conflict. Disc is compressing the nerve, which is causing pain. So there is a compression, there is an inflammation already, and there where you are using steroids, so they have got 3-4 actions. One is a strong anti-inflammatory effect. Second is washing off the inflammatory juice which has been corrected, and third is breaking off perhaps some adhesions, microadhesions, which have been formed due to inflammation. So now, out of these 3 goals of steroids which we use in the transformal or epidural route for the radicular pain, I am unable to conceive how PRP is going to affect, which itself is causing inflammation. So apart from one goal, which is washing away the inflammatory milieu, inflammatory juice collected over there, I am unable to understand, and also breaking the adhesions. But these adhesions are because of inflammation, and then what we are injecting is again causing inflammation. So I do not have any answer. Perhaps we will have some in the time. Same is with the SI joint. So there also, and especially before SI joint, I will go for the facet joint, because facet joint is perhaps the only diagnosis in entire pain medicine spectrum and before endoscopy where we actually had a very good evidence of the efficacy of radiofrequency ablation of median branch if done correctly. So I would welcome, and I will wait for some paper who compare. Actually, intra-articular steroids are not indicated anymore. Intra-articular any therapy for facet joint is not indicated anymore. The diagnostic criteria is absolutely clear, which is median branch block once or twice, in academic situation twice, in private practice or in day-to-day practice once, and then you go directly for the radiofrequency. That has got a wonderful evidence across the world, including the US. So I would wait to see a comparison between the radiofrequency of medial branches for facetogenic pain of low back pain with intra-articular PRP or PRP on the median branch. I don't know. So this is about facet joint. Third is SI joint. So same about the SI joint and facet joints. This is the same story. I agree, and there is a lot of papers for that also, because pain medicine is not only about the spine pain. There are multiple areas where, especially in the knee, I believe there is a lot of evidence, and we almost all of us have good experience also of that. But we need to publish it. So this is what I take out of it. But again, I would congratulate both Dr. Akhil and Dr. Aanchal for a very, very good presentation. I hope that all our fellows take a cue how to present a journal club. And I congratulate Dr. Sidharth for Mumbai Pain School initiative and thank you for having me here. I have really enjoyed the whole thing.
Anurag sir, answering your question previously, so I checked it again. So in the RCT where they did the discogenic pain, where they injected PRP, they did use contrast. So I just wanted to double check before finally
That's
saying it.
great.
2
That's
ml
great.
of 2 ml of contrast, answering one of the questions which have been asked, like what is
Yes,
the
yes, yes.
volume?
Now again,
And
there
the
is a
second,
problem.
sorry.
Yes, yes. Please go on. Please, sorry.
No, so the second in which they used the stem cell, the control was the sham where they just injected saline in the paravertebral muscles.
Okay, great. Thank you, Dr. Aanchal. Though Akhil already has posted this thing while you were talking about, and I asked the question. But now there is a problem on the finer details of this thing. You means we use contrast for the provocative discography.
Right, right.
And in provocative discography, actually, I believe that anybody who's doing intradiscal any therapy is doing first the provocative discography, as it has been described and given by the SIS, Dr. Charles Appel, Nikolai Bogdak, and all that, big, great people of the pain medicine. So it is, again, it is inconceivable to me if there is a simple annular tear, a small annular tear, which is causing pain at 2 levels. I do a intradiscal discography. You take my word, please. I have done few cases. It is very difficult to inject 2 ml of anything, be it contrast or be it PRP. So I don't know.
Yeah, I agree. If it is unless it's a leaky disc.
Yeah, it's a grade 4, grade 5 annular tear. Unless you just can't inject that much of work.
Because there is no space to inject. I have done a number of cases.
Yes, yes. So, I am not very much convinced about the methodology of these studies, though I have full respect to all of the researchers.
How much do you inject, sir, when you do discography? How much do you inject?
No. This is about the pain.
How much IV inject? It is how much
I can inject. Yeah.
Yeah.
This is about
you can inject. That's what the question is.
Yes. So this is about
not you how much you are thinking that how much you can. Not it's not like that. It's you are pressing and it's not going.
That's the going. And pain is increasing. The pain is the end point.
That was my question.
Pain.
Like whatever cases you have done so far, how much you end up injecting before patients start getting pain, approximately on an average?
It starts in many patients. It starts with 0.3, 0.4 ml.
Okay.
In many patients, it goes 3 ml, 4 ml. You keep on injecting because it is going into the epidural space. Okay. But most of the time, it starts around 0.8 to 1.2 ml in most of the patients. Okay. And I have done few cases of PRP. I am telling you, I haven't published it. We are just collecting the data. It will be a retrospective one. And many of our patients, in fact, I can say if I have done 10 cases, around 8 are happy after 2 to 3 months.
That is the time which they have mentioned. They say that till 2 months there is no relief, and 2 to 6 months the relief increases or becomes stable, and it stays then there for a long time.
Yes, we hope so. And we are also planning to have a repeat MRI done after 6 months, not before that. After 6 months to see whether there is any change or not. I don't know. We haven't done a single case of the repeat MRI till now, but we are planning. But apart from the disc, because you must remember, there is a study, very good paper, RCT, which have been published some 10, 12 years back, where they compared transfemoral steroids with the transfemoral saline. And you will be surprised to know that there was no difference. So we need to take the studies, all the studies with a pinch of salt. But yes, regenerative medicine has got something in it. But no size fits all, as they say in America. No size fits all. It is not going to be applicable at every place and for every plot. This, which I believe, and because I am saying this with some responsibility, because I have seen ozone going down in the LA because of this reason only. When they started is using for any Tom, Dick, and Harry problem of the humankind, it stopped working. Everything has got their own specific indications. You just can't use it everywhere for any damn problem. So this is my take on it.
Great. So I think let's focus on the questions which are there. Thank you for the kind comments, all of you. I think Dr. Senthil has asked what is your experience on using biologics. So he's already described, Dr. Anurag had described this. Dr. Sanjog has asked, do you do discography? So yes, at least some dye has to be injected before at least to you confirm the placement, but how much volume and everything, that is another question. But definitely today we raise the questions, tomorrow I'm sure somebody will find the answers. So any mention of intradiscal volume of biologic, it's not mentioned. Here I will make a comment. Nowadays I'm doing discographies only in patients where I'm doing a transdermal endoscopy just before doing that, just to see the location of the tear and just confirm. So in those cases, if the tear is big, because endoscopy is done only in cases where it is actually indicated, and in those cases the tear is very well established, and the dye wholly leaks out into the epidural space, and then you can give as much as you want. So once the channel is formed to the epidural space, you can give. But what we were talking about initially is that if it's a contained disc, like when I started doing my fellowship, and we were doing only contained discs, and we used to select our patients for APLD. That time when we used to give the dye, it will not go. That was what Dr. Anurag was talking about. Okay. So let's move to the next thing. How can we manage?
No, Sidharth, I would like to
add something.
Add one thing. Yes.
Yes, sir. Yes. Sir.
The question was about the provocative discography, and all the new friends of pain medicine needs to understand there are two terms actually. One is provocative discography. Second is evocative discography. So what Dr. Sidharth is mentioning about the evocative discography, where we want to find out where the nucleus which has come out into the canal has gone, so that he can place his endoscope there only to remove it. But the aim of provocative discography is to find out whether this disc which is showing degeneration on the MRI is actually the cause of pain.
Discogenic pain.
Discogenic pain. Disc is actually, and yes, you can find that there are 5 discs which are degenerated, and perhaps out of these 5, 4 are having some sort of HIZ also. But on provocative discography, it may happen that you find only 2 discs which are painful. Rest of them, they are not painful. So as per the, I am talking about the SIS guidelines again, in Interventional Spine Society, which was earlier International Spine Intervention Society, which is now SIS, which is Spine Intervention Society. मैं उनकी गाइडलाइन के बारे में बात कर रहा हूँ. So they are very clear that actually in the strict academic sense, you need to have one controlled disc while you are doing provocative discography to find out whether this patient is having discogenic pain or not. That means you need to pressurize one disc which is absolutely normal on the MRI. So that will work as the control disc. So if you do not want to be so academically oriented, but still it is absolutely advised that one thing, that all the intradiscal therapies are indicated only for the contained discs. Only for the contained disc. If the envelope is torn out, envelope means the annulus, no intradiscal therapy is likely to work. It doesn't make sense. Secondly, it is always good to do and document the provocative discography and try to find out some manometer if you can. If you do not want to use the manometer, please use a 3 ml syringe and measure the volume at which the patient is complaining of pain. So I think I'm just repeating the things which you already know. So that's it, Sidharth. I just wanted to.
So moving further, Dr. Senthil is asking, how can we manage increase in pain after epidural biologics? Same way while how you manage it for the knee to avoid NSAIDs. Then Dr. Sanjog is asking, any mention of incidence of discitis in these papers? So I could not find any reference. It is highly unlikely though that there is no incidence of discitis, but unfortunately or fortunately, there is no mention of discitis. This is the number one fear which stops me personally from using biologics in the disc. Okay, next is anyone tried combination of bioacuplasty with biologics? Any experience on this? Anyone? No. So I think this can be a good point. Although there is a caution from my side. I have seen that in many of our practices, what we do is we start experimenting just like that. So there is a way to experiment. If you want to experiment in this way, so the best way is to start a study, get an ethical approval, then enroll the patient in that study, inform the patient, take the consent. After that, even if there is any complication, you are protected. There is nobody in the world who can stop you, because the patient knows it, the body knows it. You have got an ethical approval through a peer-reviewed this thing, and of course you have been corrected. In ethical approval, they will point out a lot of your mistakes potentially, and a lot of things will be taken care of. So otherwise it is known as an experiment. So then that can be very dangerous. So anyone tried combination of bioacuplasty with biologics? I hope this answers. Nobody has tried, but you can do it. How many sessions of intradiscal PRP? So most of them done one session. In fact, I will repeat that I do for the knee also only one session. I will never repeat it, and it's for me, as far as my experience is concerned, it's futile multiple injections. But many of us are doing it here, who are present here, so that's okay, because many protocols describe it. I started doing it, but my experience is otherwise, so I'm not doing any multiple injections anymore now. So go to the last question. If we are injecting dye, antibiotic, and PRP all together, aren't we having a less volume of PRP in the disc? So that's very relevant point by Dr. Suresh. So are we injecting antibiotics in the disc also? I mean, I didn't, along with PRP, Dr. Aanchal, Dr. Akhil, in these papers?
They haven't mentioned about antibiotic, and dye was also in the contrast in the control group, not like the actual group.
Yes. So this is very important thing, that if you want to give the PRP, especially in the contained disc, and you want to give a sizable volume, then definitely you cannot inject other stuff. So avoid this dye and all that. So how will you inject that? Then you have to rely on the radiological APN lateral views, so that you make sure you are inside. I mean, if you are doing it regularly, so then in APN lateral you are where you want to be. So there is no reason you are somewhere outside. So I think that can be one of the things, and take the precaution. Maybe use two things are advised. One is the protective film, maybe that Ioban and all, whatever you all use, and the second is needle technique. So these two things may help reduce, and use disposable stuff only. And I think that should be at least the basic minimum structure. A few days back we were just discussing with Dr. Sasmit. So I was talking to him, and we found out that this cefuroxime is one of the drug which is used as a prophylaxis, and this can reach good concentrations. So I think use a drug which can reach where you want it to reach, so that can help. So we changed our practice slightly accordingly, and I think we will be better off in future. So any other comments, anything by any of the Anurag sir, you like to make any comments before we end the session or something?
I think I've said enough. Just about the intradiscal antibiotic. Again, there was a paper some 15 years back, perhaps more, where they compared the different antibiotics, and they measured the intradiscal concentration of those antibiotics, and they found that time available antibiotics, cefazolin, one, second ciprofloxacin, and third one, if I remember correctly, was the vancomycin. These have the biggest, largest intradiscal concentration. So they recommended it. It was published perhaps in the Pain Physician or Pain Medicine Journal at some 15 years back. Cefazolin I have used quite a lot, but now it is sparsely available in the India because of, again, is less of its value. The 1 gram injection costed only 19 point some rupees. So nobody was interested to sell it anymore. So currently, what I practice is I use injection cefotaxime, monosaf or any brand, whatever is good. I use it one shot before MIPSI, intradiscal MIPSI, and secondly, I also use, while I do provocative discography, I mix my dye with 0.2 ml or 0.3 ml of the that injectate of cefotaxime which we have injected for the patient. Like we dilute 1 gram of cefotaxime in 10 ml. We give 9 ml to the patient through the IV route and save 1 ml. And that we, out of that 1 ml, we take 1.2, 0.3 ml into our syringe of dye of 3 ml, which we use for the provocative discography. So unfortunately, till now, we have been saved from this discitis. It may happen, but as Dr. Sidharth has said, use of iodine and complete aseptic protocol. Please do not think as any other injection, percutaneous injection. Disc is, as it was a common practice among the pain physicians in at least just 10 years back. Abhi thoda change ho gaya hai कि disc is a temple. So consider it as a temple when you go into it. Even the guidelines suggested earlier, I do not know about the recent guidelines, then disc should be the last part of the spine to be investigated about the pain. If you are confused about the axial back pain, think of facet, think of myofascial pain, think of quadratus lumborum, psoas major pain, think of SIJ pain. Only then, if you have ruled them out by your examination history and perhaps sometime diagnostic MIPSIs, then you think of this. Until unless there are very striking features on the MRI and things, examination. So this has to be respected because discitis is really bad. Some of us have encountered it, fortunately not through the normal MIPSIs, which we routinely do discography, but through endoscopy. So one thing is that you must maintain the surgical asepsis. I'm using the word surgical. That kind of asepsis. I really hate to see people wearing all kind of rings and threads and not washing properly, not wearing the gloves properly, not donning. So this is something we need to bring in our practice and use a judicious use of needle into needle technique, as Sidharth mentioned. Is a very, very small but important step of discography, because you do not want, disc is unable to heal by itself. It is the largest vascular organ of the body. So all these little things we need to keep in mind.
Great. Any comments from Dr. Aanchal, Dr. Akhil?
No, thank you.
So the same thing which sir said, and it was not included in the paper also. The second point of the paper itself was responsible, safe and effective use. And in safety, they did not talk about the aseptic protocols, not just while giving the PRP or stem cells, even during collection. And it was not talked about at all. Like, it was not even a part of the key question. Not assessed in the papers as well.
Yeah.
There is another question in the comment.
Yeah, I think Dr. Senthil is asking about whether to we are actually, I think, trained to do multiple things at once. So maybe we like mocktails or cocktails. Okay. So I think that's not the correct way for thinking. You can do reverse, Dr. Senthil. His question is, do we do the transforaminal epidural steroid after PRP to get best of both worlds? So I will say do the other way around. If you actually have to do it, do take the inflammation down first, use the steroid, and then later on for regeneration use the PRP. But that is, I mean, I have never attempted PRP transforaminal. So I will avoid that as well. So for that, I will just use the old dictum: when it ain't broken, don't fix it. So I have not seen any failures with the transforaminal epidural till now, where I thought it will work. It will work. It will always work. So those of you, I think 3-4 of you are present here who have seen all my transforaminal epidurals. So I don't think if I am giving transforaminal epidural, otherwise I will not give it. But if I give it, it has to give results mostly. So I don't routinely give it in now or since last many years in like pure stenosis or something like that. In fact, today morning only we have refused a couple of cases for that. So don't use it where it won't work. So select your cases. I think that will be my message. So, but great discussion. Thank you all for participating. And this first over the this time, maybe next 5 weeks, they are going to be very exciting. We have with great difficulty and great pains, we are bringing to you this unique topic, which I don't think anybody is discussing across the world right now. So at least you will get some new things to look at. And this is purely a very interesting topic to any pain physician, because you're doing already all those injections. If you equip yourself with the correct knowledge, maybe in future at least one good indication of this can come up, and maybe a subset of patients can benefit from this. Okay, so this is the season 3 of the Pain Journal Club, and we are focusing on regenerative procedures for spine pain. So guys, please spread in the word and join for the next session as well. We have a new time, 8 p.m. Last time we experimented with 9:30. It's getting too late, so this time maybe we have chosen the middle way. So join in at 8 p.m. Indian time. We have grouped topics, and we've got 2 faculties, 2 papers. This one was a very big one, but the rest of them, we have 2 papers for all of them. And I'll be sending to you the papers in advance. And just join our mailing lists. I put up the WhatsApp group in the chat and email. We have WhatsApp groups for Mumbai Pain School, so please join them. Any suggestions, comments are most welcome. I'd like to thank Dr. Anurag sir for joining in. I'd like to thank Dr. Aanchal, Dr. Akhil for the great presentations, and all of you for listening. Let's meet up next Friday, 8 p.m. Just an announcement, we're going to have the next hands-on MIPSIs on 4th and 5th of March. So I'll put up the registration links soon. So please sign up for this, those of you who will be interested. So see you around, guys. Nice talking to you. Take care. Bye-bye. See you next week.
Thank you.